So the next thing that I want to talk about, so we talked about a few things here. The next thing is metabolic syndrome, right? So metabolic syndrome is a cluster of conditions. Metabolic syndrome includes 5 things: abdominal obesity, high triglycerides, low HDL, high blood pressure, and high fasting blood sugar, all of which raise the risk for heart disease. Now, 3 out of these 5 main factors are sort of needed for a diagnosis of metabolic syndrome. But metabolic syndrome due to ADT has some key differences that we should understand. Number one, it does not, the metabolic aberrations with androgen deprivation do not include a high HDL. As I said, they do not include a low HDL. They in fact increase your HDL, as we talked about, and we also talked about how despite increasing HDL, the net effect is still pro-atherogenic. But something to sort of keep in mind, that the metabolic syndrome that occurs with ADT is not classic metabolic syndrome. It's sort of a mimicker of metabolic syndrome. So the prevalence in the adult population of metabolic syndrome is about 20-25%, and male hypogonadism, again, is an independent risk factor for metabolic syndrome. And again, low testosterone can predict metabolic syndrome in men. ADT causes a high degree of alteration in metabolic parameters and increases this risk of metabolic syndrome. Some studies, 1/3 to about half the patients receiving ADT for more than a year will develop metabolic syndrome. A recent meta-analysis, which I show here on this slide, which included 9 observational studies and a cohort study, found that an even higher incidence of metabolic syndrome of up to 60 to 75% in this population.
So Dr. Gupta, are there people who really are just going to be the ones who get it as opposed to others? I mean, is there a particular phenotype that we can think of that would be more predisposed, or is it just somebody who happens to have a pre-existing high cholesterol or blood pressure and they're going to do worse? Do we know before they go in?
So I don't think we have data to parse that out, but what we do know from our clinical experience is patients who have uncontrolled risk factors or suboptimally controlled risk factors will obviously have a greater risk of, if your blood sugar going in is not very well controlled, you are at a higher risk of sort of having a poorer control while you get on ADT, and especially if there's a lack of awareness both for the patient and for the provider, and they've not been counseled that this could be a possibility with treatment.
So I guess we all have to be on our toes in terms of seeing people when they walk through the door.
Absolutely.